So we know that ICANS is an endothelial dysfunction syndrome, right? The CAR T activation leads to inflammatory process, and this inflammatory process causes endothelial activation dysfunction, right? And from other syndromes that are associated with endothelial dysfunction, we know that the complement plays a significant role. The complement is activated, and for example, transplant-associated TMA, the complement is a biomarker and also a target of therapy, right? So here we try to explore and describe the complement levels, the terminal complement complex levels of patients that receive anti-CD19 CAR T cells with costimulatory domain CD28, because these are the patients that have higher risk of ICANS, and describing the patients that have ICANS grade 2 or higher or grade 0 or 1. And what we found in both groups, we have shown in a match pair analysis that the complement was activated and increased levels, but the levels are higher in the patient population that had ICANS grade 2 or 4, right? But after CAR T infusion, but when you look back to the levels before lymphodepletion and before CAR T infusion, they did not differ based on the patient population, suggesting that the complement activation might be playing a role in the development of ICANS grade 2 or higher. We also look in the patients that receive prophylactic steroids, what's frequently used with the CD28 CAR T products, and we did not see a difference in the complement activation levels if the patients use or not prophylactic steroids, suggesting that the use of prophylactic steroids that's currently most employed approach to minimize ICANS may not be preventing the complement activation. We also try to understand which factors could be associated with the complement activation, and we saw correlation, independent association between the terminal complement complex levels with CAR T expansion, and also with the modified ISEC score, that is a surrogate marker of endothelial activation. But interesting, when we look to in a multivariable model, including the CAR T expansion levels, soluble terminal complement complex levels, and the modified ISEC scores, only the CAR T expansion and the complement remain independently associated with ICANS grade 2 or higher, suggesting that the complement may be a more powerful surrogate marker of the complement activation and the endothelial dysfunction in these patients with ICANS grade 2 or higher. And our data is mainly descriptive and hypothesis generated, but support further studies to evaluate the role of complement in ICANS pathogenesis and also as biomarker and therapeutic target.